Good morning, everyone. Do you see the core competencies? All right, let's begin with the overall sleep tech job and the competencies. Now, typically, I like to discuss things in order, but we have already gone through so many reviews, and I want to have some more specific discussions on some of the areas where we need the most, especially when it comes to the actual job itself and also what you need to know didactically speaking, right? Because a big portion of our job is educating patients. We have a few here that have been doing sleep for a while, for many years. And so a big portion of this is really putting everything together and addressing the patient's needs. And usually they will spend the most time with us, the techs, and not with the doctors. The doctors typically will spend 15 minutes, maybe half an hour. Some doctors might be generous to spend longer than that, but for the most part, they spend a lot of time with the sleep techs. Okay. Whether you are just starting in sleep technology or you have been in sleep for a while, these are the core competencies. Age specific. So every time you click on any of this, like home sleep testing, right, you will see some of the things that will be asked of you. These are the things that you should know. So do you understand the device? What are the different devices in home sleep testing? What are the parameters recorded in home sleep testing? So in the home sleep testing, they have a few kinds. Anybody remember the types of home sleep testing devices? We call them what? Type 3 and 4, right? What's type 3? So type 3 means you have 4 channels, and type 4 means you have how many channels?
Three, sir.
Yes, so it's the opposite. Since I already started this conversation on home sleep testing, I might as well pull it up. Home sleep test. Now it's even more important to understand home sleep testing simply because this is the majority of the sleep studies done and performed in the United States. So when you're learning sleep technology and you're going to take the RPSGT exam to become licensed, the licensure is based in the United States. Therefore, you need to study how the market is in the United States. So when you do a full PSG, of course, you understand that you will put a lot of electrodes on the head and additional parameters. You will have easy more than 10 to 14 and even more in a sleep study. You're going to have EEGs, EOGs, right? You're going to monitor respiration with a pressure transducer and a thermocouple. Then you'll have a snore microphone, respiratory belt, etc. With a home sleep test device, you will monitor mainly the flow, which gives you the patient's events. This can pick up obstructive events. However, this particular device also picks up the snoring from the flow channel. So now you have 2 parameters just within this cannula. The third is on the pulse oximeter. It gives you the oxygenation and it picks up the pulse also of the patient. So the rate, right? And then you have the respiratory channel. So this alone can give you multiple. This is what, type 3 or type 4? Type 3, minimum type 3, because it's more than 3 channels. Type 3 has 4 channels, and type 4 has 3 channels. It's the opposite. So this one has 1, 2, 3, 4 at least. But the oximeter, like I said, measures oxygenation and also pulse. So it can give you 2 information or 2 parameters just from the pulse oximeter. However, there are now newer devices such as the WatchPad right here, gives you the same without having any cannula. This home sleep test device monitors flow based on the pulse. So this is called the WatchPat. Anybody familiar with WatchPat? So PAT is what? Anybody remember what PAT is? PAT, peripheral arterial tonometry. So they measure or calculate what is the patient's flow pattern from the pulse. Instead of having a cannula, you have a pulse that will extract the information of the patient's breathing pattern from the pulse. It will also monitor the oxygenation and the rate of the patient. However, it also has the a sensor here on the chest, so it's all connected into this little watch. Oh, this is actually a big watch, right? But this also monitors the effort. So you can have obstructive and central. It can identify that. So how the technology performs that, it's a longer conversation. But this is at least a type 3 because it has four or more channels. So it has four at least that we can count right now. But it can also calculate the stages of sleep by just the pulse. Pretty crazy, right? So since I know we have discussed home sleep testing, but there are also other types of home sleep testing where the devices are attached to the forehead. So this is how it picks up the pulse and the oximetry. It will have the PPG photoplethysmograph, okay, PPG. That's the technology used for these devices. So you have PAT, peripheral arterial tonometry, right? Tonometry, Tonometry. And this one is using PPG, photoplethysmograph technology. And it also uses the flow, typical flow, but there's nothing on the hand and there's nothing attached to the chest to monitor effort. Has anyone seen this before? I know I haven't. I have seen the other ones. Just to add a couple more. So another home sleep test is this. So it just goes on a forehead. This SumFit monitors in the by using PPG also. So it monitors oxygenation. It can extrapolate the stages of sleep, measures REM versus non-REM. So it also extrapolates or pulls out and extracts the flow of the patient. So it can identify apneas. And it's just on the forehead. Wild, wild technology. So I guess all of us, we have to now quit sleep. This one is the SumFit Pro. You can attach a cannula and then you can, or if without the cannula, you can attach EKG instead, but it also uses the same device. All right, so let's go back to what we were discussing about. Oh, sorry, where did that go? All right, any questions so far? When you go through this document, which is in the chat, please print it, make notes here, and then do your own checkoff so that you can start filling out this. Once you have all of these filled out, it's going to be a pretty thick binder for you, but that's how you know you have discussed and reviewed many of these materials. Supplemental oxygen is another one. For many of us who are not respiratory therapists, we might not be using O2 all the time unless you work in a unit ward ER before or work with the respiratory therapists. But it's important to also understand supplemental oxygen because supplemental oxygen can be used with its own titration. For example, the patient is referred to by Dr. Yabut into the sleep lab because this patient is suffering from something that they don't understand, but the patient is sleepy all the time. So when Dr. Yabut refers this patient, let's say the patient's name is Vladimir. Okay, patient Vladimir goes into the sleep clinic, gets seen, and then scheduled for a sleep study. Now, when this patient, Vladimir, goes to a sleep study, then the patient might have obstructive events, right? So now the tech can perform a split night based on the doctor's orders, or if the patient has a very high AHI or apnea-hypopnea index, then the tech can split the patient. So that's usually an emergency protocol, right? What's the index? As long as severe.
So and it's cyclical and we can split them.
So when the doctor just says, okay, split the patient if the patient is severe, that means the apnea hypopnea index or apnea hypopnea per hour is more than 30. So when it comes 31, 32, 40, 50, 60, 80, what have you, anything above 30 then is considered a severe AHI. Most of the sleep labs in the United States will follow a protocol of 40, okay, more than 40. If AHI is more than 40, the tech can split the patient, meaning to say, even if the doctor just ordered an overnight diagnostic test, then the patient exhibits or shows severe AHI, then the tech can initiate the titration portion. All right. And so in other instances, the doctor will write on the order, excuse me, diagnostic study. However, split if patient has AHI of more than 15. So there are some orders that are like that. Okay, sometimes the doctor will just want any patient to be moderate range, right? What's moderate range for apnea? More than 15. Any patient with an AHI of 5 or less is normal. Okay, apneas that is 6 to 15 is mild, 16 to 30 is moderate, 31 and above is severe. So if the patient now exhibits, let's say has HI 50 and the tech is ESA, right? So ESA, now wait a minute, this patient has very severe AHI. So even if the original order is only overnight diagnostic test, ESA can now perform a CPAP titration. Now, upon initiating the CPAP titration, and ESA eventually eliminates all the obstructive events. Let's say there's no, the apneas drop from 50 per hour to 3 per hour. So that means the patient's already normal, right? However, if the patient now exhibits desaturation, but there's no clear reduction in flow. So let's see an example. Let's say you're doing a titration, and so upon titrating, so you're increasing pressure, and then all of a sudden, this is now all these apneas disappear, right? So if the apneas disappear, let's say the patient now, if you look at the flow channel, there's really no apneas here, right? Even though you have some irregularity on the breathing, this is because the patient is in REM. So that's not the whole point of this discussion. Let's just say that you're titrating that patient, and then the patient doesn't have any more events and not even any reduction in the flow, but you start to see that the patient is now at 86%, 85%, 86%, 85%, 84%. So the patient is desaturating. However, you don't really see any obstructive events, not even a hint of hypopnea. So if you see a reduction in flow and it lasts for how long? What's the minimum requirement for an apnea before you address it?
10 seconds.
So if the reduction in flow and you have a desaturation and it lasts 10 seconds or longer, okay? If it's shorter, you don't touch it. Anything that's less than 10 seconds, it's not technically an apnea. So that's clear. You do not address those events. Okay, you let it go because you have to have a clear evidence that this is identified as a hypopnea, apnea, or central apnea, meaning you have to have at least 10 seconds of an event. Now, this is in REM. So in REM, typically we will have erratic breathing and erratic heart rate also. But now you don't see a reduction in flow and you just see desaturation. So if you do not have a qualification for that patient to identify that they are having an apneic episode or having hypopneas, you can actually introduce what? Exactly, oxygen. If the patient is still having, and the rule is if the patient's baseline oxygenation is less than 89%, lasting more than 5 minutes, and there is no other evidence of apneas, etc. And you should also try to see if you can reposition the pulse oximeter, right? You will always check the pulse oximeter to see maybe it's just that the patient has a bad finger, or you just need to adjust the pulse oximeter. So you do that first before you introduce oxygen. Okay. Now you reposition the pulse oximeter, and the patient is still saturating below 89%. So it's 87, 85, 84, and it's barely going up to 90%. But the patient is not having any apneas, meaning to say this patient is requiring oxygen supplemental oxygen titration. This is when you will introduce oxygen. For the most part, this protocol is already established in the sleep lab. If not, what would you do? You call the medical director, or you call the doctor on call. Sometimes the medical director is not the one to be called, but the doctor on call. So in our sleep lab right now, where I work, we identify the entire week's on-call position, which is usually the sleep fellow. So the sleep fellow, these are doctors usually that are pulmonologists already, or internal medicine doctors, or ENT doctors that are undergoing training for sleep specialization. So they are called fellows until they graduate. Once they graduate, then they are full-fledged sleep doctors after they pass their board exam. So they are usually the ones that will take the call. But you're right, you can call the medical director. Any questions on that?
Scenario question. This is happening, a decrease in the O2 below 89, but this is happening during REM. Do you reposition the SpO2 while the patient is on REM, or do you wait for an arousal and then you get in, reposition the O2, the SpO2
Yeah,
back
that's a
again?
good point.
We have been told in the lab that I'm working at during REM not to disturb the patient and just wait for an arousal before you can get in and fix something like the oximeter or sensors.
It depends, because one, if the patient just got into REM, don't disturb them because
Mm.
they're trying to get through their first cycle of REM. And so when we get into REM sleep, how many cycles do you really need all night? We will go through 4 or 5 cycles of REM to get good sleep. So now, if you're titrating and you just got the patient titrated, the patient is now in REM. That's the patient's first REM. Okay, but now you have desaturation and there's no apneas. If you wait too long, then you will not optimally titrate the patient. If the patient ends up in REM rebound, that means the patient will be in REM for a long time. So the earlier you fix the desaturation, or allow the patient to be titrated while in REM, then the better for the patient, because you can find out your optimal pressure and optimal settings. However, if the patient just got into REM, right, and maybe this patient had difficulty falling asleep in the beginning, so it was pretty rough, and finally now the patient is asleep, then you're going to go in there to fix things. So that's the scenario. I would probably wait for that initial arousal. And typically, when you go into REM, you will have multiple arousals unless you are in a very long REM rebound. Because the goal for the text is to find optimal pressure, optimal setting. So if you don't interrupt the patient, even in REM, and the patient may be in REM now for an hour, would you still wait?
Ano?
Then you won't. You should not. The patient is obviously in a REM rebound if they already last more than 5, 10 minutes. So let's say you've been waiting 10 minutes, the patient is still in REM, and the saturation is persistent. You should go in there and fix it because the patient will be in REM rebound. And even if you wake up, the patient will go back to their own cycle. If you have the patient optimally titrated, they have a good pressure, and you open up the airway, they're breathing right, they will go back into REM. The goal for you is to eliminate the aspect that the patient should have been in oxygen to have optimal saturation, not just optimized sleep pattern, but also optimized ventilation. Remember that optimal titration is not just REM supine for 15 minutes. It also requires normal AHI oxygenation and leak. So if the other parameters are not met, that is not optimal titration. So again, if your patient is on REM, supine, not having clear apneas, but you have desaturation, that's not optimal titration because you cannot give that prescription to that patient and base that prescription on a suboptimal saturation. Remember that optimal titration per definition is REM supine for 15 minutes. However, it has additional parameters. You cannot have high leak during optimal titration, then it's not considered optimal titration. You cannot have optimal titration if the patient's saturation is also abnormal. So you have to have a stable REM supine. Okay. As sleep techs, it's easy to put electrodes on the patient's heads. There's no way that you cannot learn how to put electrodes on the patient's head. Even if I just watch YouTube and I practice it on a patient, yes, I will be nervous to do it my first few times. But after you do it a few times, it becomes easy. What's hard is understanding what's happening, understanding what's behind the scenes, understanding the physiology that occurs, understanding why are we having REM, and then why is my respiration or ventilation erratic? Why is my pulse erratic? Why is it only happening during REM? That's what's hard, is understanding the science, the medicine, the technical component behind things. And that's why we're here. Some of you will be challenging the RPHT exam. Some of you are just learning because majority of the time we will be teaching patients. We will be teaching our colleagues. That is one of our major jobs. And the other thing I wanted to point out is that recently I have our lead tech go over the doctor's orders. When you run a sleep lab, you will get orders from your sleep doctors. And so we will review the sleep study for, let's say tonight, we have 4 patients. The lead sleep tech will go over the doctor's orders, and the doctor's orders will say, okay, this patient, 73-year-old male, blah, 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 perform overnight PSG. Split if the patient has AHI of more than 30 or 40 or even 5, whatever the order is. Sometimes the order doesn't make sense, right? Sometimes the doctor will write there, patient has COPD, please perform diagnostic study. So our lead tech will contact that doctor who ordered that study and ask. And usually the tech will ask, hey doc, you ordered a diagnostic study only for this patient who has COPD. So the question there is for the doctor to maybe consider a split night. Okay? Because if your patient has COPD and suffering from any sleep disturbance, that's why they're being seen in sleep, right? That means there is a high probability that patient with COPD might have apneas. That's why they are symptomatic. So it makes sense for the order to be a split study versus a diagnostic study, right? If the doctor only orders a diagnostic study, it limits the technologist from performing a titration. So the order must be a split study because you already have an idea that this patient has a tendency to possibly be positive for apnea. Let me give you a better example. A patient that the doctor ordered a split study. This patient, if the AHI is more than 30, and you look, the patient is a 60-year-old man with BMI of 50 and have excessive daytime sleepiness, had previously got into a car accident. So what does that tell you as a clinician, as a technician, as a technologist? What does that tell you? The patient is very severe, very high BMI. High BMI means what? Morbidly obese. Do you think that patient will suffer from hypoventilation?
Yeah.
Absolutely. Once that patient lays down, all that fat, that weight will press on that patient's thoracic cavity and on the lungs. So it will not allow for the patient to breathe appropriately. You know for a fact that morbidly obese patients, they have hypoventilation, especially that high of a BMI. Not all obese patients have high BMI. Here in the United States, we have a BMI of over 30. You're already overweight, over 35, then you're obese. And sometimes it doesn't look like they're so heavy. But if you have a high BMI of 50, 60, that's really big. And so that patient, as soon as they lay down, they are for sure to have some hypopnea or desaturation hypoventilation. My point here is that if you already see and guess that the doctor ordered only a split night, if I see an AHI of this, but what if the patient has major desaturation? Can I give O2? So you're thinking ahead. You're thinking of what will happen. If you have a question, you need to follow up immediately with the doctor or your lead tech or your medical director or your manager. Why? Because that order must be corrected. The order to give you more freedom to perform other interventions. So what am I asking for here? If you already that this patient might have hypoventilation, what are you going to ask for? Because the doctor only ordered a split study. That's it. What are you going to ask for? Would oxygen be appropriate?
O2 supplementation.
Yes. So at least you ask for, hey, doc, can you modify your order? Or can you tell me if I can apply supplemental oxygen? Because I'm expecting this patient to have a lot of desaturation, even if you titrate the patient. The other consideration, if you have severe or morbidly obese patients and they can have really bad desaturation, is you need to make sure that you can perform bi-level titration. Take a step back and look at your patients. If your patient is OSA, obstructive sleep apnea patient, what will be your intervention? Correct. Now, if the patient is uncomfortable with CPAP, what else can you give the patient? Bi-level, spontaneous. However, if the patient now has some central apnea, what else can you give the patient? So you will go from CPAP to bi-level spontaneous once the patient shows some apnea. That's the key word, some central apnea. Okay. So when I say some central apnea, that means it's not constant, but the patient shows some central apnea. You can apply bi-level spontaneous time mode, ST mode. All right. Because you want to eliminate that central apnea. Now take note of this, if the central apnea goes beyond 50% of the events, that's when you can consider what you just said. What is that?
ASB.
ASV, exactly. Adaptive servoventilation. So and then there's another mode, right? So we discussed CPAP for OSA. If the patient is uncomfortable with CPAP, you can put them on bi-level spontaneous mode. If the patient exhibits some central apnea, you can put them on bi-level ST mode, right? Now, if the patient has hypoventilation or a lot of desaturations, you cannot treat that with CPAP. It has to be spontaneous mode, right? So you don't jump straight to spontaneous time if the patient is just exhibiting hypoventilation, like a lot of desaturations, a lot of hypopneas. You will increase pressure support to give them more volume of air, okay? And then if they show some central, then you put them on ST mode. If the central goes beyond 50% of your events, let's say every epoch you will see central. Now you're talking, oh, okay, this is a lot of central apneas. You either have over titrated or the patient really must be placed on ASV mode. ASV mode is the one that's appropriate for central. If the patient has hypoventilation, ASV mode is contraindicated. It might come from a fellow, might come from an outside provider and say, hey, I think this patient has central. They told me they have central. I'm requesting an ASV titration, and then it goes into your sleep lab. So you have to question that. You have to make sure that the patient does not have hypoventilation. Any patients with hypoventilation is contraindicated for ASV. And since we already mentioned ASV, what is the other contraindication for ASV? Low ventricular ejection fraction. If the patient has less than 45% of left ventricular ejection fraction, if the patient has less than 45% LVEF, that means they have major heart issues. They cannot use ASV. And these are the protocols. And lastly, what's the other mode that we haven't talked about is the volume assured pressure support. So you see how quickly this can go in different topics. When you are performing titrations, whether you're performing CPAP, you went to bilevel, you're performing bilevel ST, or even ASV, or even VAPS, volume assured pressure support. Now, you already eliminated the most important component. What is that most important component that you need to eliminate when you're doing titrations? Obstructive apnea. That is your number one goal, regardless of what type of titrations you're doing. CPAP all the way to advanced modes with ASV and VAPS. You eliminate obstructive events first. Why?
So that we can see if the desaturation is due to obstruction only.
Yes, that's one. Okay. So when you talk about ASV or VAPS, you're trying to eliminate hypoventilation with VAPS. You're trying to eliminate central apneas with ASV. Okay. And the way they perform, we will discuss that. However, this is why you must eliminate obstructive events first. When you increase IPAP or you apply pressure support, right? You put them on bilevel, you have IPAP, EPAP. And ASV and VAPS, these advanced modes, these are bilevel devices. They have IPAP and EPAP. Now, how can you increase IPAP if your airway is closed? How can you ventilate the patient? If you're having some obstructive events, you do not need to increase pressure other than your EPAP or CPAP. If you're doing CPAP titration, you increase your CPAP. If you're doing bilevel, you increase your EPAP, right? Because your EPAP is your CPAP. Again, your EPAP is your CPAP. That's the pressure that's constantly going in and out, going into the patient, whether the patient is inhaling or exhaling. I'm sorry, this is very elementary, but the most important component here is for us to understand that you first need to open up this airway. And you open this airway with your CPAP or with your EPAP. When you have this now stable, you can ventilate the patient. You can increase your IPAP pressure. You can change and increase your pressure support. You can increase your inspiratory time. You can change all other parameters if this portion is open. And you can only open that with CPAP or EPAP. That's your number one goal. That's why you have to be careful when you're doing ASV, VAPS, all these titrations, even bilevel ST. You have to be careful increasing too much pressure because you can overventilate the patient immediately. You have to just be careful in opening up the airway first and then ventilate the patient. All right. Do you already know how to inspect electrodes? How do you maintain electrodes? So we have discussed infection control, but I just want to reiterate this because we consume data all the time. We consume TikTok, CPAP, we consume YouTube, we consume everything, but we just watch. It's different when you're studying and you're learning. You need to write. You need to write. You need to create that connection on writing what your thoughts are and what you're listening to. so that it can be maintained in your long-term memory. Remember, you're not many of the students here are taking the RPHET exam, but many of the students here are learning sleep technology. Now, let's go to polysomnography. This is really what we are, who we are, right? But the biggest part of our jobs is, again, like I said earlier, is the education. We have to be the best educators for our patients. So that's why I'm teaching a lot of didactic. I don't just teach you how to click, which one to click to open up a study. Having the knowledge behind the scenes, creating the connection for the patient's signs and symptoms into what disease could that be and how could we treat it, how could we maintain it. Those are the information and knowledge that you need to understand fully in order to educate your patient. Why? Your patients that you meet in the sleep lab can ask you questions at the beginning of their journey in sleep, or they could have questions towards the end of the clinical management. They could ask a question in the middle part. What about CPAP? We haven't even done an overnight study, but they're asking about CPAP. So they can ask questions in any parts of their sleep management, clinical management. That's why we have to be very knowledgeable when it comes to the pathology, some anatomy and physiology, then intervention. What are the interventions? You're talking about PAP, the therapy. You're talking about maybe I want dental appliance. No, but how do I get there if I haven't been tested? We have to be knowledgeable on home sleep testing, overnight study, the actual recording. And then we have to be familiar and knowledgeable about maybe pharmacotherapy. Some patients will be on medications, and how does that affect their sleep patterns, or etc., whatever the questions are. And some questions will be on, I already have been using CPAP and I quit 2 years ago. Why? Because I was having issues with my mask. So we have to understand now, understanding how and what are the troubleshooting with the masks that we can discuss with the patients. So can you see that we have to know a lot of information? So it's overwhelming, but if we understand the core concept, right? If we understand that we need to know the main pillars of sleep technology, then we'll be okay. So that's why I'm always presenting this list, because you can get overwhelmed. Oh my God, we're talking a lot. We have so many information to know. That's if you're thinking about the details. But if you think about the few core competencies, is that too much? How many is this? 11, right? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. 11 core competencies. They have a lot of details behind it. But if you organize your perspective, your thinking, the way you memorize things into just 11 concepts, then you will not be overwhelmed. Let's say when you're now studying for the RPSGT exam, right? And you go to RPSGT exam, and what do I need to know as a sleep tech? And then you found the list. Oh, I think Kem said that I need to know this. So look at this list. This is a lot. So if you think about it in details, it's a lot. But if you think about it in major categories, it's only 11. Now, this is the big part of our job also, sleep health educator. Okay. But we need to know everything. All right. Let me stop here for a minute and ask if anybody has any questions. So when you perform multiple sleep latency tests in MSLT, we perform MSLT and MMWT. These are our only two sleep studies that are done during the day. But MSLT, what's the purpose for MSLT? So the purpose for MSLT is to identify the cause of excessive daytime sleepiness if the patient is negative for apneas. That's the core concept. If your patient has excessive daytime sleepiness, they must be negative for apneas. If they are not, if they even have an AHI of 6, your MSLT has to be canceled. because that patient is an obstructive apnea patient. Okay, so
Mhm.
it doesn't matter if your apnea index is only 6, 5.5, or 7, 8, doesn't matter. If the patient has an apnea, AHI is abnormal, MSLT can be canceled. Now, can the doctor sometimes continue with the MSLT? Yes, it's their call. Your doctor can order whatever they want. It's their license. They can make us do whatever studies they want for the patient, depending on their goal. Have I seen MSLTs perform even after we find out that the patient is positive for OSA? Yes. The only reason is because some patients have what they call a COMISA. Learn what COMISA is. This is a comorbid insomnia and sleep apnea. Meaning to say your patient has both. Okay. However, like I mentioned earlier, the priority for sleep medicine is first to eliminate the obstructive apnea. If the airway is closed, it doesn't matter if you're giving the patient medicine to keep them awake, because they will always have a closed airway and the apnea will always be there. That's why in patients with comorbid insomnia, you need to fix the apnea first. So what will happen then if your patient, say tomorrow night you have a sleep study, but that patient is also scheduled for an MSLT the following day. Okay. And for everybody's just note taking, you cannot perform an MSLT or multiple sleep latency test if you don't have a PSG, a diagnostic study. So every time you schedule an MSLT, it must be a diagnostic sleep study followed by an MSLT, because that patient must stay in the sleep lab the night before to make sure that they sleep for at least how many hours?
6 hours po.
Yes, the patients must sleep for at least 6 hours the night before they perform the MSLT all day. So you can only prove that by having the patients in the sleep lab the night before. So we always perform PSG, then we do the MSLT the following day. That's why you have to have a night tech and a day tech. And the day tech will come in early to take over that patient, because the patients will not be awakened before the night tech leaves. No, the protocol is that the night tech will allow the patient to sleep until the day tech comes in. And if the patient is still asleep while the day tech already arrived, they will not wake the patient up. For the most part, we allow the patient to sleep in. And when they wake up, then that's when we start the nap. You will start 2 hours after they wake up. Then you will do every 2 hours of nap. Total of how many naps?
4 po.
Four.
Five.
Five.
5 naps. We have an update in the ASM guideline. You will always do 5 naps. Okay. That's per ASM guideline. For those you're taking a test, you do not put 4, you put 5.
Okay.
MWT, you can do 4. So we can discuss MSLT and MWT also, but in a different time. MSLT, these two daytime studies, we need to talk about them more in depth. So going back to COMISA, there's a reason why if your patient has positive OSA, then you cancel their MSLT and let the patient go. Sometimes the doctor will say, no, I suspect this patient has COMISA, so continue with the MSLT. So sometimes the doctor will say, I have a patient who is suffering from daytime sleepiness, but I think we did a sleep diary and the patient has some type of insomnia. So I think even if this patient has some apnea, I think this patient also have insomnia. With that said, I want to order a PSG plus MSLT for this patient. So this patient, if positive for apnea and the apnea is severe, I want you to titrate the patient. And after you finish titrating the patient and the patient wakes up in the morning, you continue the MSLT. When it comes to polysomnography, again, this one is big. So can you see the left side? You see how 8 pages, right? All the way to 8 pages. And I don't want to jump back and forth, but some of these things, as you read them, and make sure you read them, it pertains to how you handle patients. So it doesn't specify on the examination. When you go to the examination and when you go and just study on how to be a sleep tech, it doesn't specify that we will be psychologists, but we definitely apply psychology. We definitely apply some skills in making the patient feel comfortable, right? Some of the things we do for the patient is to calm them down, make sure that they are not anxious, or if they're anxious, we try to alleviate that by offering some water. Some of these are techniques to allow the patient to relax, because the goal for us is to have the patient sleeping, right? So how can you sleep if you're stressed out? How can you sleep if the tech is rude? Simple things like that. Or the tech doesn't accommodate you when you are so hot. Patients can have a very bad sleep study if they're not comfortable, or if they don't just jive well with the tech. Sometimes you rub the patient wrong by being talking too much, by not talking at all, or just not giving them any information that might help them relax. We do a lot of psychology in sleep. And if you look into the list here, not only do we act as the technical experts when it comes to identifying what are the artifacts I'm seeing, how do I troubleshoot that, but we also identify, is the patient okay? I think this patient is stressed because the room is too cold. And that's when all the other competencies play a role in polysomnography, right? So the competency here, this age specific, will discuss these different things that we observe and that we have to be aware of when it comes to our patient population. And then when we understand this fully, we can then do our PSG very well. Now, does that make sense? Is that connecting both okay, clearly? So we also have been discussing pharmacotherapy because we have to understand some of the side effects. We are discussing polysomnography, meaning we're doing the sleep study, but we're talking about Prozac eyes right here. We won't know this unless we discuss pharmacotherapy, which we did. So when you're doing a sleep study and you notice this patient's Prozac eyes, and let me see if I can pull a good example on, because it's hard to mimic that. So Prozac eyes is not normal. Okay. This is Prozac. It's a good example of Prozac eyes. Okay. Now we're looking at, these are your eye electrodes, right? EOG, electrokilogram, your chin, and then your C3, C4, O1, O2. All right. And this patient appears to be, what do you think is this stage? And don't be afraid to make a mistake. It's
Two.
okay. I make mistake. Yep. Two.
Pulse Cortis 2.
Yeah. At first when I saw this, I'm like, wait a minute, that looks like REM, right? Doesn't this look like REM?
Yes.
Like it's very sharp. And so you have an out of phase, in phase, out of phase, in phase. So it could be REM. However, here, what is this? This is not REM. This is SEM, slow eye movement. Agree?
Yes.
So how can you have REM and then have SEM? That's abnormal. Unless you have an arousal in between, so it will change the sleep stage. You will have these issues, and these are not common. And when you have uncommon events that happen to you, whether you're new in sleep or you've been in sleep for 12, 15 years, wait a minute, this is weird. This usually doesn't happen, or first time I've seen this. Always think of medication effects. Always think of medication effects. when patients have some kind of medication, it will alter some of the normal variants into abnormal variants, right? And it can throw you off. And here you can see that this looks to me like a spindle after a K complex, but it's very sharp, so it might not be a K complex. But this appears to be a sleep spindle. But this is abnormal, having REM looking events. All of a sudden, it's slow eye movement without any arousal. This patient didn't wake up. It's continuous EEG. Agree? Do you agree?
Yeah.
The EEG doesn't seem to have any interruption or disruption. So how can you jump from REM to SEM? That means this patient has Prozac eyes. So there's a possibility that maybe this is N2 or maybe this is REM. Because the chin is very low, right? And this is not clear K complex. Maybe this is just spindles. Spindles, usually they don't show up in REM. They show up in N2. They can show up in N3, but not in REM. I've never seen them in REM. But then, if this patient is taking Prozac, you can see it. This patient can have now delta activities. Okay, even if this patient has everything is N3, right? Everything. If this were delta, big waveforms, and then you see eye movement like this, I can bet you that patient is on some heavy medication, particularly SSRIs, antipsychotic or antidepressants. They can be, if they are on antidepressants, yeah, you can see some Prozac eyes, what they call Prozac eyes. Okay, I just want to highlight Prozac eyes because some of these terminologies need some explanations. When it comes to polysomnography, we need to identify emergency equipment and location. What does that mean? Not all sleep labs are in a hospital. If you're in a hospital and you have some emergency, let's say a code blue, right? You have a code blue. You have to have a crash cart if you're in a hospital. But some sleep labs are not hospital-based. Some sleep labs are in a community center where they don't have anybody else but just a building and a security guard at night. So what's your option? What's your option if you don't have a crash cart? AED, right? Has anybody been trained on AED? I think all of us should have AED training because of our CPR and BLS certificates. Yes?
Yes.
Yes po.
Okay, good. So AED, you must check that. If you are the lead tech, senior tech, lab manager, or you're the only tech, you need to check that AED at least once a month. Okay? You need to check the AED once a month. Make sure that it turns on and that you just don't use it on yourself to test it out. Okay? Because you'll die. Just test it out. Now, identify location of emergency exits. And why is this important? Because we can have natural disasters. You can have all of us, you're doing a sleep. It happened to us. I'm from California now, so it's very common here to have earthquakes. All right. So it just happened to me within the last 2 weeks again. So we get earthquakes often here. So that's why we need to know emergency exits, and we sometimes we will do it on a regular basis where we will test out ourselves. The hospital usually will run that. Okay, today we will generate a drill, an emergency drill for earthquake. So when they start the drill, you know exactly where to go, what door to exit, how to get out of the building, and where to be when you exit the building. There's an area where all the staff will go to, okay? So it's important because of that natural disasters. Maybe there's fire. So that this is why we do emergency drills. But these knowledge is also testable. This can show up on the examination, but this is also very important to know. Doesn't matter where you're at, whether you're in Saudi, UAE, Philippines, California, it doesn't matter. You need to be aware of your emergency policies, emergency protocols, knowing where to exit, what to do. And you don't just run out. Okay. If you have patients, you have to recover them. You have to get the patients out with you. Okay. Let's say you see your doctor, both of you are outside, and then your building crashes down. And wait a minute, where are your patients? Don't leave your patients behind. Describe appropriate process for the emergency response team. So each location, whether you're at, you should have an emergency policy or emergency protocol. You have to read that, okay? And I'm saying that now, not just to discuss this, but you really need to understand your emergency protocol. Whether you're already in sleep or not, this is very important. And now, when you talk about HIPAA, what are we talking about when you say HIPAA? Anybody? What do we mean by HIPAA? People still awake?
Yeah. Data
The confidentiality.
Yes. No, I didn't need to click that one. HIPAA is actually so HIPAA is a law. It's Health Insurance Portability and Accountability Act. It started in 96 in the United States, and it is important because this is how we protect our patients' information. So when you say in our elevators, there are notes on the elevators, and it's clearly stated there in bold letters, do not discuss patient information, patient cases. And if you do discuss patient information and you're in an elevator, you do not discuss that patient's name, date of birth, or anything that is personally identifiable information, or PII. Okay, PII, personal identifiable information. If you discuss a case, hey, Dr. Kazaya, I have a patient. This patient is suffering from excessive daytime sleepiness, and I think we're going to move forward into doing an MSLT. That's okay. You didn't say anything that identified that patient, and you're in a public space, or you're in an elevator, or you're eating in a restaurant, you're in the cafeteria. But when you say, hey, you know that patient in room 7A, Miss Fields? Yeah, I think she's suffering from that is a violation of this HIPAA Act. If you get caught stating any identifiable information, you can get in trouble. You can get fired by sharing information. Is this clear? I have one quick story. I work in San Diego and I work for this Filipina sleep doctor. So her community of patients are Filipinos, retirees. So one night, I only see two patients in that lab because it's only a two-bed lab. But I was talking to one patient, and this patient has a hard time hearing. So what happens when your patient has a hard time hearing or they're hearing impaired? What happens? Anybody? They're loud. They speak very loud. Okay. So when you have patients that talk very loud or they tell you, hey, I can't hear. What you need to do is you don't need to scream. You need to lower your voice, like more bass. Okay. Because what happens when you get older is you lose a lot of high frequency capability. You lose the ability to hear high frequency. So instead of saying you're talking, hey, Mr. Yabut, can you do this? So you have to lower your voice as in, hey, hello, sir. My name is Tin and we need to. So do you see what I'm saying? The lower your frequency, the better they can hear you. Okay. But anyway, the story is that this patient was screaming because he couldn't hear me. So we're talking, and all of a sudden, the other patient from another room walked into the other patient's room. So I'm like, oh my God. The first thing I thought was HIPAA. Because they should not be knowing each other. They should not be hearing each other's issues. However, the funny thing was that this patient on the other side can hear my patient who is screaming and heard that they know the same people. So the other patient came to the room and said, "Hey, did you say this was your auntie?" And my other patient said, "Yes, that's my auntie." He said, "Is your last name this?" And the other one said, "Yes." I was like, "Oh my God, HIPAA violation all out." And he said, "Oh my God, that is also my auntie." So my patients actually were related to each other. So anyway, that's the moral of the story is I should have closed the doors so they don't hear each other's information. But we're happy at the end of the night because now they found out they're actually families. All right, moving forward. Questions on HIPAA? No? All right. Demonstrate knowledge of patient rights and responsibilities. So this is very important for patients to let you know that, you know what, Jeremy, I don't want to do the CPAP. You know, like we're doing a diagnostic and then you said, "Hey, Miss Melai, we were doing a study and I noticed you have severe apnea, so I need to put you on a CPAP." What is that? This is the device you put them, you let her try it and say, and then Melai says, "No, I don't want it." So you cannot force the patient to use it. Okay. As soon as the patient says, "I don't want to do that," then you just continue with diagnostic tests. Clear? Demonstrate knowledge of professional ethical behavior. That's why when you go to a sleep lab, any sleep lab, even the one that you're in now, you have to read all the policies and procedures because sometimes what you learn here from me might not be the actual policies and procedures in your sleep lab or in your area or in your hospital or in the country where you are working. Make sure that you know the policies and procedures. So it might vary, and it does vary all the time. All right. And interaction should always be professional. Yep. You can make the patient feel comfortable, but not unprofessional, right? Not to, you always have to maintain professional conduct, even if you're joking around with patients. And this is important, ladies and gentlemen, because sometimes the patients might read you wrong. Does that make sense? Has any of you encountered anything that's inappropriate where you're working, whether it's sleep lab or RT department or any ward or any? Has any of you experienced anything like this?
Inappropriate behavior from a patient?
So when it happens, you make sure that you have space and that you conduct yourself professional, especially if the patient is trying to get you to, oh, let me joke very inappropriately, sexual jokes or racist jokes, right? Because especially you don't know if that patient is just trying to bait you, right? So don't bite into it. If they touch you, that's a different story. Or if they threaten you with words, that's a different story. You cannot continue the sleep study if the patients threaten you with harm or they are overly, say, inappropriate. You have to stop the study. Once they make you feel uncomfortable, you can stop the study. You can call your doctor, your manager, your supervisor and say, "Hey, this is what happened." Annotate it, put it in the chart and say, "I don't feel comfortable anymore. I feel unsafe." You can call security or you can tell them you need to stop the study and then you need to let the patient go. All right. Any questions on that? No? Infection control. Infection control, for the most part, we do not have really severe patients where they are, say, they're very infectious in a sense that you have to wear a gas mask or be covered up. And this used to happen during COVID era. We were still seeing patients, and because of aerosolization of COVID, we were wearing N95, then a face mask, then a gown along with our gloves. Very hot, very uncomfortable. But that was during COVID. Now we're back to normal. We just wear our not even N95. We just wear our surgical mask unless the patient is exhibiting any signs and symptoms of fever or whatnot. Then usually we send the patients home. If the patient's already there and they just develop the fever or any other symptoms, then you have to take preventative measures. You have to put on N95, put a face mask on, etc. Okay. Demonstrate knowledge of equipment, sensor, etc. So this is another important thing, right? I discussed that all sleep systems are very much alike. Has anybody here used multiple sleep systems in your jobs, or you always just have one type of sleep system in your lab right now?
Per hospital.
Oh, so what hospital? Ano nang mga systems na ginamit mo?
In Grail, then dun sa isang
Grail. So let's look into trying to look for the waveform, not the actual device. For those, has anybody here used Knox before? Anybody else?
No.
No? Okay, so Knox is very interesting because they're very proprietary, meaning to say, when you use Knox, they will use their own electrodes, right, Tin? Because it comes in a package that's attached to this forehead contraption. So this acts as your ground, but it's also connected to all the other wires. So it's already pre-set for you, right? So it's a quicker setup in a sense that this is already preset. So this attaches to your main breakout box, because this is a breakout box, and then so it's already labeled, etc. That's why it's not hard to use one system to the other because they all have labels. So E1, E2, you can see the inputs on the side, which is see here, you can plug in the 3.5 millimeter connectors. And it's typically, this is your leads are male. And then the input to the devices are female. Or it can be vice or opposite. The end of the leads can be female, and then the input on the boxes have a male connection. But regardless, they're all labeled. Okay. So EMG here, EOG for your eyes up here, and F3, F4 for the frontals, C3, C4, and then so on. And then your reference, M1, M2. And for the legs, then you go on the other side, right? You will have leg leads, and then you can attach the CPAP titration usually in another channel that's in the main head box. Okay, and because CPAP bilevel, the titration systems is not through the breakout box, it's attached to the actual system. And that's usually a direct current or DC channel. So we will go into that further later. But this is the Knox that Tin was talking about. And I want to discuss Alice. So when it comes to Alice, it is bigger, heavier, but it's also labeled. So you hook up your patient, tape the electrodes, plug it in there. As you gather them together, some of them you will use belts. It's already labeled, so you know where exactly to plug them in. And it has arrows, right? Your EKGs here, you see the heart. You see the heart icon? So you plug in, usually we use 3 at least. So right arm, left on the mid-axillary, and then what is this? So usually we use just 3. Okay. And then the snore microphone here. So the whole setup is plugged into the box, including the pulse oximeter. Usually it has right here at the bottom. If you're using Alice, it's very bulky, but it's simple. Who has used Alice here aside from Tin? Jeremy, have you used Alice?
We use Alice right now.
Oh, okay, good. So you use Alice 5 or 6. Once you start recording, they all look alike. All right. Once you start recording, the main difference with all the systems are the buttonology. Where do you click? What do you click? Okay. And if this is what I wanted to finish off for today are the systems. Okay. So regardless of what system you use, Compumedics Grail, A1 or T3 is their home sleep test. Compumedics Grail also has their own home sleep testing equipment. Okay. The Philips Alice, that's from Philips. They also have their own home sleep testing equipment. But all the truth behind all these systems is that they all share the same design. What do I mean by that? There's three major parts. Okay. One is when you start a study. Right? One is when you start a study. And the other one is, what do you think is the other option? You start a study, the other one is what? Is you analyze a study. Go ahead, what?
Yeah, that's it.
Yeah, so you start a study or you analyze or score a study. Sometimes is on the terminology. So when you open up a sleep system, the first thing you'll see is whether you start a new study. Sometimes they don't call it a new study, they call it a new collection, right? But it pertains to the same thing. You're going to begin a sleep study, you click on new collection or new study. But when you are now the day tech. Vladimir now works as a day tech, right? Let's say he comes into the lab. Last night, who worked last night? Let's say Chris worked last night. So Chris last night clicked on the new collection or new study or new acquisition. Okay, that don't get confused with the terminologies. So this way you can jump from one system to the next. Now that Vlad comes in, I'm the one scoring the study, so I go to the acquisition or analysis, right? Some systems you click on analysis. When you click on analysis, it opens up this. You will already see the recording, okay? So this is true in all sleep system. When you click on a recording, you will click File, Open. Or if not File, it will be Patient, Open. When you click Open, you'll see a list of patients. You choose the patient and you open that file. There's no mystery behind any of these sleep systems. They're all the same. And just to reiterate, I've worked with Compumedics, I've worked with Alice, Natus, now Polysmith, Cadwell. So I've worked with a few of these sleep systems. And that's why I can tell you that they're all the same. They're all the same. No mystery. So don't be afraid to use any new system. When you open it now, you're in analysis and or you're in a collection. You will always have multiple tabs on top. And these sometimes they are icons because when you get used to a system, you don't need to go file, then click a drop down menu. If we click and do a drop down menu, that's usually Windows based. And all of the sleep system are what? All of the sleep system are Windows based. So the functionality are the same. How you click, right click, right? They're all the same. You can control C. Most of the shortcuts are the same because it's Windows based. There is no sleep system that I know of that is Mac or Linux for now. It's all Windows. And correct me if I'm wrong, if you're working with a computer system, a sleep system that is Linux or Mac, but all of them, instead of the drop-down menu, you get familiarized with icons so that, okay, I need to check impedance, click here. Or I need to change how I'm looking at this. I don't like this workspace. I don't like this separation of EEG here, and then I have the respiratory here, right? I want to flip this upside down. I want to move the EKG below. So you can have shortcuts up here, or you can go to the channel and hold the click, and then you drag it down. That's how you can rearrange how you're looking at the sleep system. Okay. And the other sleep system is that you go on the montage, like this is a montage, right? This is a montage how your channels are arranged. Some sleep systems, you have to go to click a montage and then you have to click and unclick. There are boxes to choose. If I don't want to see this, I don't want to see F3 and F4. I want to see just F3. I just want to see F3, C3, and O1, which is the recommendation. We don't need to see all of these, right? I just want other people, and I want to see F4, C4, O2. That's all I want. Okay, then you can go and unclick this. You can also even right click and then delete channel. You can do that. You can always add them back in. Okay. My goal here is for you guys to understand that when you touch a sleep system, that they're all the same. What is your purpose? Are you trying to start a study, or are you trying to analyze or score a study? So the third part is after you're done reading or scoring, then you move that study forward. And that's when it can go through to a folder where you will store that study. And that study now will be accessible to the doctors to interpret the study. Sometimes the doctor will just go right in the same analysis folder, like how you access analysis, and they will interpret the study from here, right? And all the sleep systems will always have an option to go file and create a report, or file, generate report. That's after you already read the study. Okay? Questions? Any questions? So here, if you're looking at this, I can tell you right now that this is not 30-second epoch. Do you agree? Disagree?
Yes.
Yeah, this to me is 2 minutes. The reason I see a big line here, this to me, these big red lines is 30 seconds each, right? So this, you can change how it looks. You can change a 30-second to 2 minutes or 5 minutes or 10 minutes. Then you can see it further out. All right. So that is that for sleep systems. One of the most important thing now with sleep systems is that, this is Polysmith. This is what we use in UCLA. Polysmith is by Nihon Koden. But I can tell you right now that some of the sleep systems who also provide EEG systems, right? They will have so much more options. Like this. Alice they have some, but not too much. Okay? Because Alice is by Philips, and Philips, they don't really produce EEG systems. Okay? Now, Compumedics, Neon Codin, Cadwell, Natus, these are big companies that produce sleep systems and EEG systems or neuro systems. So when the companies that you use also produce neuro systems, expect to have a lot more capabilities, a lot more configuration. You can customize these things. You can take out some of these things. There's just so much more options. Now, is that better or worse? It doesn't matter really. The most important thing is that you have the capability to perform the sleep study, and then you have the capability to analyze or score the sleep study. And then you have the capability to create the report. Once that is done, doesn't matter. The other portion, after you have performed the recording, you scored the recording, then the doctor analyzed the recording and interpreted the study. Now the doctor has created a diagnosis for the patient and a treatment plan. After that is done, the next portion is to store all these data, the storage. And why am I saying this? Is because you are part of that. The techs are always part of the maintaining of the storing or the storage of the studies. And so we do have to understand some basic computer concepts because we troubleshoot. We are the ones that will be working with the IT. We are the ones that will be calling tech support. So we have to become familiarized with some of the IT lingo, some of the IT skills. Not a lot, very minimal. But when you store a study, the tech or the IT will have some questions. And so you have to be familiar with it. Some IT, when you already have trouble with your data, let's say you're trying to score a study or you're running a study and then it freezes. The recording just stops. So now you call tech support. hey, my scoring just stopped. What happened? So the tech will ask you, okay, where do you keep your files? Is it on a server? Is it local server? Are you guys using a cloud server? So you have to understand some of these concepts, and we can discuss that in a different time. But definitely, I advise you to understand some IT concepts. It's not going to be in the competency, but it's really important, especially when I train people, I want them to be trained to be at least on a lead tech or to a lab manager capabilities. So when I teach you all the other perspective that can help you become a lead or a trainer or a lab manager. So I always give you some of these inputs so you can have an edge over the other techs. All right. Sorry about all that. Any questions, concerns, last minute? Anybody still awake?
Yes.
No questions, Cam. Thank you.
Opo.
Okay, good. So I know it's late. For those who need to sleep, go ahead. You can log out. If for those who are staying, I can discuss a couple more items because I know some of you guys it's already super late there. And some of you already just came back from work. So I won't be offended if you go to sleep. I encourage you to go get some sleep. All right. For those who don't have any questions, go ahead and log out. And for those who are staying, I'll discuss a couple more items. Okay. All right. So again, if you feel like you're already tired, ready for bed, you can just say good night on the chat and you can log out. It's okay. All right. Let me continue with this polysomnography. There's not going to be so much more. We're going to end after a couple of items. All right. So discussing polysomnography, we have done a little bit of overview, preparation, safety. We did discuss HIPAA, equipment orientation, right? So most systems are going to be the same. And this is important because we are the troubleshooters. Even if you say that we just run the sleep studies, no, we don't. We run and maintain it. So you have to understand the components of the sleep system, right? So when you look into a sleep system, say this, I think Jeremy, you're talking about this model right here, right? The one on the left?
That one, yeah.
Yeah, so it doesn't have the capability of a full EEG
EEG.
recording. Yeah. So if you look to the right, that's the one with all of the EEG slots available. And this other one, there's even a bigger one here. Can you see this one? This one has even more EEG slots. So you can do what do you call it? An inter EEG recording. When you do that, you can add more EEG channels when you're doing research or you're doing traumatic brain injury patients. Let's say you have F3 to F5, then you add another electrode in between them. So it creates like a 44 channel EEG alone. Okay. But anyway, going back to the sleep systems, this particular sleep system, we used to call this a head box, right? And in some systems, this is not the head box. This is the breakout box because this is what you break out of the main system configuration. This is what you give to the patient. This is what you're attaching the patients to. So this is the breakout box. This is considered the head box, but in Alice, it comes in a PC looking device. Okay. In other sleep system like Natus or Grail, it doesn't look like that. And let me see if I can find an example. Okay. I hope I'm not getting you dizzy when I'm scrolling so fast like this. So here, can you see the screen?
Yes.
So your breakout box is this, the ones where you plug in the patients. And the head box is this, right? And for Alice, it's that little PC looking thing. But that is what connects into the patient. And this head box is connected to the main PC in the tech room. Okay. And so you already are processing it here. This is the amplifier now. This amplifies everything that you record from the biophysiological signals from the patients. Okay, then it gets processed here. Because from the patient to the head box, it's still biomechanical, biophysiological activities, right? You will pick up electrical activity and then it's coming from the patient's physiology, and then it turns into electrical. Then it's changed, right? It's again transferred or converted into digital data. And that's why we can manipulate it after the recording because it's digitized. Now, understanding the concept of the input and output from the patient to the breakout box, from the breakout box to a cable going to the patient's, going to the head box. And from here, you also connect through the direct current or DC channels, your CPAP right here, your titration machine. This is connected to the head box. Okay. And usually, if this is ResMed, this is connected to another link, another box, which is connected to the head box, or it can go straight to the computer. Okay? It can go straight to the computer because they are all in the same network. The same network. Okay? So the idea here is you have inputs from the patient, which is alternating current. This is AC. So this can come out of the examination also. Okay, just FYI. This is AC and alternating current, but the titration system, the pulse oximeter, if you also run a capnography or CO2 monitor, whether it's end-tidal CO2 or transcutaneous CO2, that is connected via direct current. Okay? So it doesn't have to be plugged into the head box. It can plug in directly to the amplifier, or it plugs into a network hub connected to the computer in the tech room. Is that clear? A lot of information. What my goal here is for us to understand that anywhere you plug, unplug, plug, unplug, all these areas from the patient, you attach, reattach. These areas where you connect and disconnect from the electrodes, the finger probe to the head box from the breakout box to the head box to the computer. All those junctions where you connected them are areas of troubleshooting. And these areas can create the possible artifacts. That's why you have to understand, where do I need to correct or troubleshoot? Is the artifact coming from the head box? Is the artifact coming from the breakout box? Is the artifact coming from the electrodes? Is it coming from just the reference electrode? Is it coming from the F3, F4, or is it coming from a ground electrode? Is it coming from the patient where I attach the electrode? Right? Is it coming from the finger, the pulse oximeter, or is it the finger itself? Or is it the room? Because the room now is cold, affecting the patient's blood flow. And so I have low saturation. Now I have to fix it from here. Or is it coming from, is the artifact coming from the CPAP titration machine? So this is the mentality, the perspective, and how I would like you to think when something goes wrong, right? When you're looking at a sleep study and it doesn't look perfect, right? When it doesn't look correct, you have to be quick in understanding, where do I need to fix? Okay, look at this recording. Is this a good recording or is it a bad recording? Or what do you observe? Real quick, this is the last one. What is your answer?
Yeah, bad recording.
Bad recording. Why? Why? What do you observe? What do you see? What could be
M1 is
fixed?
off. Yeah.
Say what?
M1 is off.
M1, right? This is not normal,
Yeah.
right? What is this? It's just this looks to me like
Came
it's
up.
not it doesn't even look 60 hertz. It looks just a really bad connection, right? The other ones look okay. Patient is still awake, probably, or stressed, or a lot of muscle, right? But this M1, no, I won't even call it M1. Why? Because it doesn't show here on C4 to M1. Do you agree?
O2. Yeah, could be the O2.
So it's the O2, right? So I go to the patient, go back to the patient's room, and I go to his room. I say, "Excuse me, sir, can you turn to your right or left so I can get back at the back of your head?" And when I do that, I'll check. I already will bring another electrode that already has paste so that I can just replace it. I will already hold a Q-tip with new prep or with the prep solution, or I can just walk in here and say and check. Oh, it's coming off. Oh, I need a paste. I need more paste. Okay. Once you go in there, fix it, go back out. And once I go back out, I look at the recording and I see that the recording now looks like this. Oh, it's very blurry, but I don't see that M1 anymore. So I'm good to go. I'm done for the night. Okay. So I hope that creates some ideas as to when and where do you troubleshoot. You have to think about the junctions. You have to think about the areas where you plug and where things are connected because the artifacts can start from there. All right. Any questions? Last minute. I'm just showing you some of these things, but we can discuss it more later. Gold electrode cups looks really nice. They have good recording too, but the best for the exam is silver chloride. All right. I'm gonna stop sharing. Any questions? Last minute. Any questions?
Yeah.
All right.
Thank
If
you.
no questions, I will have this recording available in a couple of hours. I will also upload the ones that I did about yesterday or for you Saturday morning.